Prakati, you can go live now.
Yes. Good evening, everyone. A very warm welcome to the ISA National online postgraduate classes that is held every Monday or Tuesday evening. These classes are designed for the postgraduates to provide them with a deeper and better understanding of clinical anesthesia. I am Dr. Prakriti Singh, and I have just completed my postgraduate training from R&T Medical College, Udaipur. It is my honor to be the screen coordinator for today's session along with Dr. Gayatri. Before commencing today's session for the evening, let us all invoke the blessing of the divine with Saraswati Vandana. Today, we'll be having an interactive session on the anesthesia for laryngectomy in a case of carcinoma larynx. Before proceeding further, I would now like to take the pleasure to invite our Honorary Secretary, ISA National, Dr. Sukhminder Bajwa sir, to please share his valuable words with us. Over to you, sir.
Thank you, Dr. Prakriti. Yes, the topic today is of very much importance from clinical point of view, theoretical, practical point of view, because many a time these cases are kept either as a short case or sometimes a long question and theory also comes along with that. But we will be dwelling upon the class a little later. We will take a short break with the President, Sir Dr. Bala Venkat sir here. And he's on a mission today. So that's why he's showing his good benign presence to us. Bala sir, for your kind words.
Thank you so much, Honorary Secretary Dr. Bajwa, and thank you very much for welcoming and inviting me to be a part of this PG class on the World Health Day. And very, very great beginning, divine beginning by Saraswati Vandana. I get really inspired after listening to the prayer song, which puts things in the right perspective, and also extremely happy to see how the PG classes are being conducted with inputs from such young minds. And thanks to Gayatri Deshpande for starting the session, and Prakriti for that clarity in which you are conducting the session. Hearty congratulations. And I'm also extremely happy that we have two learned professors to moderate the session today. And I wish all the young postgraduates who are going to present and interact with the two learned professors a very, very fruitful time. So, being the World Health Day, it released the next newsletter, our ISA National Newsletter paper, for which the editor-in-chief is Dr. Sukhminder Singh Bajwa. Thank you, Dr. Bajwa, for compiling an excellent newsletter. And this newsletter is really significant for more than one reason. Each one of us, a landmark event for Indian Society of Anesthesiologists to sign a memorandum of understanding with the American Society of Anesthesiology, and the cause of that, he has written a special article being every member of the Indian Society of Anesthesiologists. And also, I feel a proud moment to share my thoughts as president of this body by sharing my thoughts to every IS member through this newsletter. So I was enamored to see the article to the
Sir, you
that
turn
needs
your
to be
screen off. The voice will be much
physiologist,
clearer, sir.
physiologist.
Turn the video off, sir.
Hello?
Yeah, sir. Yeah.
Audible?
Yeah, better, little better,
Hello?
sir. Yeah, little
Okay.
better, sir, now.
I take the opportunity to congratulate and thank all those who have written their thoughts in this paper newsletter. And I wish every postgraduate goes through this newsletter because it's extremely worthy going through these articles. And thanks to Dr. Bajwa and the entire editorial team for compiling this to release the newsletter on behalf today in this postgraduate class. And at the same time, before I conclude, I wanted to thank Dr. Madhuri Kurdi, Dr. Manaswi, Dr. Nishanta Hai, Dr. Praveen Chako, Dr. Sriram for your contributions for this PG class. Thank you so much, Dr. Bajwa, and I hand over the proceedings back to Dr. Bajwa.
Yeah. Thank you, sir. Thank you for your presence and your kind words. And this newsletter contains the very historic MOU also, which we signed on 16th of February 2025. And it's a pride moment because the first time ASA has come to the ISA and we have signed that MOU. And in this newsletter, we have got a letter from the president of ASA. We are highlighting the importance of the partnership between these two large societies of the world in relation to the webinars we're going to connect together and the other academic exchange programs. And it will be released today only in the evening to every group of the ISA National. So it's worth reading, and I think that's how the thing keeps on going with the progression. With Dr. Bala Venkat and myself, we are representing the ISA National at the moment. So it's a great privilege to be releasing in this very sacred platform, the ISA newsletter. Thank you, Bala sir, for that, being here with
Thank
us.
you. Thank you so much. Yeah, thank you.
And coming to the class part, I think it's one of the important classes, which I already told. So we are sharing the airway with the surgical team. Then there are different complications, there are different comorbidities in such patients. The post-operative courses can also be stormy. Intraoperative are always tricky in these cases. So many things are concerned with these type of cases. I think we've got a very good team today under the dynamic leadership of Surya Siri ma'am. So I request Dr. Prakriti to take it forward from here.
Thank you so much, sir. And thank you, Dr. Bala Venkat, sir, for sharing his valuable words with us. I would now like to request Dr. Gayatri to please introduce our esteemed faculty for the evening and also to clarify the rule and the format for the session of today. Over to you, Dr. Gayatri.
Thank you, Dr. Prakriti. Good evening, respected faculties and all the audience. I am Dr. Gayatri Deshpande. I have just completed my postgraduate training from R&T Medical College, Udaipur, and it's my honor to introduce faculties for today's class. Respected Dr. T. Suryashri ma'am, she is professor and head of the Department of NTR University and Health Sciences. She has 30 years of PG teaching experience. Her specialty interest is in trauma and pediatric anesthesia. Ma'am is retired additional director of medical education of Andhra Pradesh State. She is former HOD of anesthesia department of Government Siddharth Medical College. She is former member of research committee of Dr. NTR University of Health Sciences. She is former member of AP Jivandan. She is also a comprehensive cardiac life support instructor and advanced cardiac life support instructor. She is also a volunteer in Mission Smile International. Welcome, ma'am. Now, I would be pleased to introduce another faculty for today's class, respected Dr. Govardhini ma'am. She is a professor of NTR University of Health Sciences. She has 13 years of teaching experience. Her specialty interest is in pain medicine, regional anesthesia, and neuroanesthesia. She is international trauma life support instructor and also basic life support and advanced cardiac life support instructor. And she is also a SMILE chain accredited anesthesiologist. Ma'am is a fellow in Indian Academy of Pain, fellow in musculoskeletal ultrasound, and Indian diplomat in regional anesthesia. Welcome, ma'am. I would now like to tell a few rules of today's session. Audience will be kept muted throughout the session. Audience is also requested to keep the videos off throughout the session. If you have any queries, you can put them in the chat box and all the queries will be addressed later at the end of the session. Now, I request today's faculties to please take over the session and introduce your residents for today's class. Over to you, ma'am.
Good evening to all. At the outset, I wish to thank our ISA Honorary Secretary, Dr. Sukhminder Bajwa sir, Academic in charge, Dr. Madhuri ma'am, and our Dr. Bal Venkat sir for giving us this opportunity. Laryngeal carcinoma posted for laryngectomy, we decided about this case because this is a post-laryngectomy, it's a change in a patient's life, and it is done only in advanced centers where it requires a multi-team approach. And one more thing is preoperative correction of all the comorbids will help to improve the patient outcome. And there's always the challenge of shared airway and difficult airway, which is anticipated. Having all this in our mind, we thought this would be an interesting case for discussion. With this, I hand over to my colleague, Professor Dr. Govardhani, to introduce our postgraduates.
Okay, good evening, one and all. It's a privilege for us, our institute, to be a part of ISA National online class session. So today's presentees of the webinar are Dr. Sriram, Dr. Manashwi, third year, final year postgraduates, and Dr. Praveen, second year postgraduates. A good luck to all of you. So let's start the webinar. So we start the webinar with the case presentation by Dr. Sriram.
Thank you, ma'am. Good evening, all. Thank you so much for giving this opportunity. The case is a 55 years old male patient belonging to Gannavaram, Vijayawada, Andhra Pradesh and security guard by profession. Admitted in ENT department with the presenting complaint of hoarseness of voice for 2 years and noisy breathing since 3 months. History of presenting illness. Hoarseness of voice for 2 years, which is insidious in onset, progressive in nature, continues throughout the day, no aggravating or relieving factors. Not associated with pain. Noisy breathing for 3 months associated with shortness of breath, New-York Association grading grade 3. Patient underwent vocal cord biopsy and tumor bulking under general anesthesia 1 month back, after which the noisy breathing subsided. No history of cough with sputum, no history of hemoptysis and hematemesis, no history of neck trauma, radiotherapy and chemotherapy. No history of difficulty during swallowing and no history of any neck mass. Past history. No history of diabetes mellitus, coronary artery disease, bronchial asthma, bleeding disorder, dental caries, and no history of any drug allergies. Personal history. History of smoking since 40 years, 4 cigarettes per day, total pack years of 8, stopped smoking 2 weeks back. Alcohol, 180 ml per day for past 40 years, last took 2 months back. Mixed diet, normal appetite, normal bladder and bowel movements. Medical history, patient is de novo hypertensive, patient on tab telmisartan 40 mg morning and night and tab cilidipine 10 mg morning and night. Surgical history, patient underwent a vocal cord biopsy and tumor debulking done under general anesthesia 1 month back. Family history is insignificant. General examination, patient is conscious, coherent and cooperative. Patient is moderately built and moderately nourished. No pallor, icterus, clubbing, generalized lymphadenopathy and pedal edema. METs more than 4 METs. Vitals. Pulse rate is 76 beats per minute, normal in rhythm, good in volume. BP 140 by 90 mmHg, right arm supine position. Respiratory rate 16 per minute. Saturation is 98% room air. Temperature is febrile. Anthropometric measurements. Height is 160 centimeters, weight 55 kgs, BMI 21.4 kg per meter square. I'm sorry. I'm sorry. Systemic examination, CVS, cardiovascular system, S1, S2 heard, no murmurs heard. Respiratory system, bilateral normal vesicular breath sounds heard. GIT, no abnormality detected. CNS, no focal neurological deficits. Airway examination, adequate mouth opening, admitting 3 fingers, nicotinic staining of lips, gum, teeth, buccal mucosa, and hard palate. No loose tooth. Malampatti, grade 2. Thyromental distance is 6 centimeters. Hyomental distance is 5 centimeters. Sternomental distance is 12 centimeters. And neck movement, flexion, and extension in normal range. So rigid video laryngoscopy was done, and exophytic growth was seen involving the right true vocal cords extending anteriorly up to middle 1/3 of the right true vocal cords, posteriorly up to posterior commissure and right arytenoids, superiorly into the ventricles, and inferiorly into subglottis. Neck, no palpable neck nodes. So, summary, a 55 years old male patient, security guard by profession, presented with the chief complaint of hoarseness of voice for 2 years, which is insidious in onset, progressive in nature, continues throughout the day, noisy breathing for 3 months, and a known case of smoker and alcoholic since 40 years. On examination, patient with stridor, which is in inspiratory phase, and rigid video laryngoscopy showed exophytic growth involving right true vocal cords. So provisional diagnosis, a 55 years old male patient, known case of smoker and alcoholic since 40 years, and exophytic growth involving the right vocal cords associated with hoarseness of voice and inspiratory stridor, which is malignancy of larynx or vocal cord. Proposed surgery is total laryngectomy under general anesthesia.
Okay, Srinam, you said that the proposed surgery is total laryngectomy. What do you understand by the word total laryngectomy?
Madam, total laryngectomy is a surgical removal of a complete laryngeal structures which involves epiglottis, hyoid, and a part of a upper trachea, and creation of a permanent tracheostomes. A part of a total thyroid gland may be removed as a part of this surgery.
What is TNM classification for laryngeal cancer?
Madam, T is the primary tumor, in which T1 is the tumor fixed to the subglottis region, and T2 is tumor extended till the vocal cords, with vocal cords are mobile and no mobility of the vocal cords were involved. And T3 is tumor extended to the larynx and vocal cord mobility is fixed. T4A is tumor which is extended to the cervical or tracheal or cricoid cartilages beyond the larynx. T4B is tumor which extended into the carotid areas. Whereas N0 is no regional lymph nodes involvement. N1 is single ipsilateral lymph node involvement, which is less than 3 centimeters. N2 is single ipsilateral lymph node involvement, which is 3 to 6 centimeters. And 2B is multiple ipsilateral lymph node involvement, which is less than 6 centimeters. And 2C is their bilateral or contralateral lymph node involvement, which is less than 6 centimeters. And N3 is regional lymph node involvement, which is more than 6 centimeters. M is for the distant metastasis. M0 is no distant metastasis is found. M1 is distant metastasis is present.
So, as per TNM classification, what are the indications for laryngectomy?
Madam, T4, which is T4A or T4B, are generally taken into the total laryngectomy procedures, ma'am.
What are the other types of surgeries indicated in laryngeal cancers?
Laryngeal biopsies, laryngectomy, which is partial or total laryngectomy, acute emergency tracheostomies, podectomy, transoral robotic surgeries, laryngeal framework surgeries, and endoscopic resections.
So what are the preoperative concerns in this patient for you?
Preoperative concerns, mainly the nutritional status of the patient is important, ma'am. Basically, these patients have an iron deficiency anemia, which is most commonly seen in these patients, ma'am. And generally, the carcinoma larynx is always involved with the comorbidities, mainly with serious ischemic heart diseases. And most of the patients who came to the carcinoma larynx are chronic smokers, ma'am. So lung involvement is much more commonly involved in these cases. As there is a narrowing of the tube, the PFTs are not advisable in this or not accurate in these procedures, ma'am. And Cardiopulmonary testing is also not advised and contraindicated in these procedures. As a result, we take a dynamic staging of metabolic equivalents were taken, and patient with more than 4 meds are ideal, ma'am.
Okay, you said in the history the patient is having hoarseness of voice and stridor. What does it tell?
Yes, ma'am. Madam, hoarseness of voice and stridor gives that vocal cords are getting involved into this. Vocal cords are involved, madam.
Okay, what are the differential diagnosis for hoarseness of voice?
Hoarseness of voice, inflammatory conditions, structural deformities, neuromuscular disorders, and palsies. In inflammatory and infectious conditions, chronic laryngitis and erythenoid granuloma, and structural deformities, vocal cord polyps or vocal cord nodules. And in neuromuscular, Parkinson's disease, multiple sclerosis, motor neuron disorders, and in palsies, vocal cord palsies are seen. These are all the conditions which seen in hoarseness of.
So the patient is having stridor. What type of stridor does he have?
Madam, stridor, it is in the inspiratory phase of the stridor.
What type
Inspiratory
of-
phase of respiration. Ma'am.
So what type of stridors are there?
Madam, basically 3 types of stridors are there, ma'am. Inspiratory, expiratory, and biphasic. Inspiratory stridors generally seen in obstructive lesions above the vocal cords, whereas expiratory stridors, lesions of thoracic trachea or primary or secondary bronchi, and a biphasic stridors are generally seen in lesions of glottis, subglottis, and cervical tracheal lesions.
Okay, in the history you asked for history of radiotherapy.
Yes, ma'am.
What is the significance?
Madam, in radiotherapy, the chance when a patient underwent a radiotherapy, we are concerned because there is a chance of difficult intubations because radiotherapy induced fibrosis, which cause stiffness and reduced mobility of neck and surrounding tissues, ma'am. And edema radiation can cause swelling in the airway tissues and trismus with difficulty in opening of the mouth, which make intubation and other procedure difficulties. And laryngeal edema is also present, and there is a frozen larynx, ma'am, which the vocal cords are fixed. Your vocal cord palsies.
So by this we can suspect we can face a difficult airway access. Okay.
Yes, ma'am.
Okay. What are the positive findings that correlates with the risk factors that we find in the history that correlates with the carcinoma of larynx?
Madam, basically patients, male to female, in more carcinoma larynx is most common in male patients, and chronic alcoholic and smokers, and patient is having an hoarseness of voice and stridor, ma'am. These are all the positive findings in my case.
Okay. Patient is also a smoker.
Yes, ma'am.
Okay. Okay. What are the ill effects of smoking?
Yes, ma'am. Smoking is consists of gaseous and particulate forms, ma'am. Gaseous forms is basically carbon monoxide, which increases the carboxy hemoglobin levels, which causes the left shift of the oxygen dissociation curve and absolute reduction in the blood oxygen content, ma'am. Reduced delivery of the oxygen to the tissues. Whereas the particulate forms mainly consist of the nicotinic levels, which is a stimulation of sympathoadrenalic systems in the blood. Sympathetic system which causes raised epinephrine and norepinephrine levels and raised cortisol levels.
Okay. What are the advantages of cessation of smoking? So what are it's brief about their duration of cessation also.
Sorry to intervene. I'll take a sec. Dr. Sriram, your voice is cracking in between. So if you can
Is it
please
moving?
switch off your video and just tell the answers.
Sure, ma'am. Timeline, ma'am. Ma'am, am I audible?
Yeah. You're audible. Audible now.
No, it causes reduced carbon monoxide and nicotinic levels, 48 to 72 hours carbox.
What happened? It was all okay. Please continue. Madam, I think he has gone offline.
Madam, am I audible?
Yes, you
Yeah,
are audible.
you're
Please continue. Everything is okay. Please continue.
Okay. If a smoking cessation and timeline in less, if it's smoking is stopped for 24 hours, there is a reduced carbon monoxide and nicotinic levels. If it's stopped for 48 to 72 hours, carboxyhemoglobin level normalizes and improves ciliary functions. If it's stopped for 1 to 2 weeks, there is a decreased sputum production, and 3 to 4 weeks, wound healing normalizes. Whereas 4 to 6 weeks is an improved pulmonary function test, and if it's stopped for 6 to 8 weeks, the immune function and metabolism normalizes. And if the smoking is stopped for 8 to 12 weeks, reduced post-op morbidity and mortality, and more than 6 months, equalize the risk of post-operative pulmonary complication as that of a non-smoker.
Okay, with this, we finish the pre-op assessment. We go to the investigations. Dr. Praveen, please present your.
Thank you, ma'am.
Praveen, please share your PPT.
Madam. Good evening, all. Here, I am discussing about the investigations what we have done to this patient, which are as follows. This includes complete blood count with blood grouping and typing, renal function test with electrolytes, liver function test with coagulation profile, blood sugar levels, thyroid function tests, and ECG with 2D echo. And imaging modalities which include rigid laryngoscopy, chest X-ray, and contrast enhanced CT of the neck. Here the investigations in complete blood counts, patient's hemoglobin is 15 gram percentage, and he had elevated WBC counts with 17,500, and his platelets were around 350,000. Blood sugar levels were normal around 83 milligram per deciliter, and liver function tests are all normal. Coagulation profile and thyroid function tests are within normal range. His renal function test with serum creatinine 0.0 milligram per deciliter, and creat clearance has 72 milliliter per minute, and all the electrolytes are within normal range. His serology, all hits are negative, and blood grouping is B positive. This is an ECG which doesn't show any significant change, and his 2D echo has no regional motion abnormality with the left ventricular ejection fraction 60%. Chest X-ray PA view shows bilateral inflated lung fields, and we have done PFTs which showed poor efforts due to inspiratory and expiratory obstruction. Lastly, we have done contrast enhanced CT scan of neck, which shows soft tissue density lesion seen involving glottic and supraglottic regions with minimal extension to subglottic regions. Superiorly, this lesion is extending up to hyoid. On post-contrast study, lesion is showing heterogeneous enhancement involving adjacent thyroid cartilages and bilateral arytenoid cartilages, where right side is more involved than left.
You finished the pre-anesthetic assessment and investigations. How are you going to stratify the risk and explain to the patient's attendants and the patient?
Optimization of this patient, ma'am.
No, how do you stratify the risk?
Stratification of the risk. Okay, ma'am. Here in these cancer patients, we have few scores like POSSUM and SOT score. SOT score is nothing but surgical outcome risk tool, where the risk prediction which estimates the risk of death within 30 days of inpatient surgery. In POSSUM score, the physiological and operative severity score for enumerating mortality and morbidity, which includes physiological and operative components, where operative components are 6 and physiological components are 12. Physiological components are age, cardiac signs, respiratory signs, pulse, systolic blood pressure, potassium, sodium, ECG, Glasgow Coma Scale, and nitrogen. Operative scoring systems which include operation magnitude, number of operations within 30 days, and blood loss within each operation, peritoneal contamination, recent malignancy, and timing of the operation.
Okay. What is the Montgomery rule?
Montgomery rule, it emphasizes patient's autonomy, ma'am, where doctor has to provide every material risk to the patient and every alternative therapy. It should be completely patient-centric.
So with all this risk scores, are they really useful in carcinoma larynx patients for risk stratification?
No, ma'am. Risk stratification scores doesn't pose a great role in stratification of
They're not
carcinoma.
very specific for carcinoma larynx. Okay.
So in this case, you have done the pulmonary function test.
Yes, madam.
Is it really required? Is there any significance?
No, ma'am. Pulmonary function tests are not really indicative in these cases because of obstruction, madam. Obstruction of the glottic inlet doesn't allow patient to completely perform the pulmonary function test, madam.
Okay. How do you assess the airway in these cases?
Airway assessment in these patients incorporate history and bedside examination, madam. In history, we ask for patients any voice change, dysphagia, breathlessness, stridor. All this history makes us to know whether patient can lie flat or he has difficulty in sleeping or waking up with shortness of breath, madam. These are the signs of airway obstruction.
So with this, we finished pre-op assessment and investigations. We will go to the case proper. Dr. Manasvi will present the case. Over to Manasvi. Muted.
Manashvi, you are not audible. Please unmute yourself.
Ma'am, am I audible now?
Now you are audible.
Yes, yes.
Ma'am, am I audible now?
Now you are audible.
Okay, thank you, ma'am. Good evening, everyone. Today I will be discussing about intraoperative management in this patient. We have kept monitoring standard ASA monitors like non-invasive blood pressure monitoring, ECG, pulse oximetry, ETCO2, and we have even kept venous access with 2 loge for IV cannulas. And we have kept temperature monitoring with nasopharyngeal probe, urine output monitoring, and we have kept invasive arterial blood pressure monitoring for this patient. And we have even kept long tubing for breathing circuit and gas sampling tube. And we have maintained normothermia by warm IV fluids and body warmers, and nasogastric tube was kept in place after intubation of this patient. Coming to the pre-medication, we have pre-medicated the patient with injection glycopyrrolate of 0.2 mg, injection ondansetron of 4 mg, and injection midazolam of 1 mg, and injection fentanyl of 110 micrograms according to body weight. And we have induced the patient with propofol of 110 milligrams according to body weight, and we have given muscle relaxant of injection vicuronium of 6.5 mg. And we have intubated with video laryngoscope to this patient, and we have intubated with 6.5 mm cuff flexometallic ET tube, as there is a narrow chlorotic aperture and exophytic growth. And we have kept the patient in supine position with a shoulder roll for gentle neck extension and arm stuck to sides to prevent compression of any neurovascular structures. And maintenance, we have maintained with volatile anesthetics of sevoflurane 0.6 to 1% and nitrous to oxygen within a ratio of 2:1. And we have maintained with injection with vicuronium of 1 mg of 0.02 mg per kg body weight in a graded doses. And we have kept ventilation settings of tidal volume 340 ml, respiratory rate of 14 per minute, inspiratory to expiratory ratio of 1:2, and PEEP of 5 centimeters of water. And we have kept IV fluids with a maintenance fluid of 95 ml per hour. In the first hour, we have kept for 570 ml, in second hour 332 ml, and third hour 332 ml. And after laryngeal separation, thorough suctioning was done in this patient, and endotracheal tube was withdrawn, and 8 mm flexometallic tube was inserted into the trachea and secured to the chest wall by sutures. At the end of the procedure, endotracheal tube was removed, and tracheostomy tube of 8 mm was inserted through the stoma. And at the end of the surgical procedure, adequate respiratory efforts were seen and reversal was given to this patient, and tracheostomy tube was connected to TPs with 10 liters
Excuse me, Dr. Manaswi, your voice is breaking.
of
Madam, Dr. Manaswi's voice is not heard. It's not audible.
Yeah, Manasvi,
and vitals for maintain stable throughout the procedure, and patient was shifted to ICU for further management.
so before anesthetizing, what will you
Ma'am,
ask?
am I audible now?
Now you
No,
are audible.
you please switch off your video, Dr. Manaswi.
No, can
And
you hear us?
whatever you
Ma'am?
read in the previous slides, I think you can just repeat because we are not
Am I
able to-
audible now?
You are audible, but whatever you told in the previous slides was not audible.
You repeat the last 5 slides, ma.
Yes.
Okay, ma'am. I'm repeating from the position of the patient. And patient was in supine position with a shoulder roll placed to allow for gentle neck extension.
Again, not heard, ma.
Hello, ma'am. Am I audible now?
Yeah, you are audible, please.
Yes, ma'am. I'm starting from position of the patient.
No.
Patient was kept in supine position with a shoulder roll placed to allow for gentle neck extension and arms stuck to sides to prevent compression of neurovascular structures. And we have maintained with volatile anesthetics of sevoflurane 0.6 to 1% and nitrous is to oxygen with a ratio of 2:1. And we have maintained with injection vecuronium of 1 mg with a dosage of 0.02 mg per kg body weight. And we have kept ventilator settings of tidal volume of 340 ml, respiratory rate of 14 per minute, inspiratory to expiratory ratio of 1:2, and PEEP of 5 centimeters per watt. And we have kept IV fluids of first hour for 5 hour 332 ml and maintenance fluid of 95 ml per hour. After laryngeal separation, thorough suctioning was done and endotracheal tube was withdrawn and 8 mm flexometallic tube was inserted into the trachea and secured to the chest wall by sutures. And at the end of the procedure, endotracheal tube was removed and tracheostomy tube of 8 mm was inserted through the stoma. And at the end of the surgical procedure, adequate respiratory efforts were seen and reversal was given. And tracheostomy tube was connected to TPs with 10 liters of oxygen. And vitals were maintained stable throughout the procedure, and patient was shifted to ICU for further management.
Okay, ma. Before you anesthetize this patient, what are the 5 questions you try to ask yourself?
Before I anesthetize the patient, I will ask, will I be able to pre-oxygenate the patient, or will I be able to use face mask ventilation to this patient, or will I be able to get a good view of cords, or will I be able to intubate the patient? And last question is I will ask myself is will I be able to get an easy front of neck access to this patient?
So why are you avoiding preoperative tracheostomy in this anticipated difficult intubation?
We are avoiding preoperative tracheostomy for a longer disease-free segment of trachea to be available for the
Honestly, there is some disturbance. Please. Not clear.
patient of stroma after laryngectomy, stromal recurrence, and we can also we should avoid pre-tracheostomy in these patients.
So how do you prepare for front of neck access in these patients?
Dr. Manasvi, there is a lot of disturbance in your
You
voice.
answer from Sriram's please.
Or somebody else can answer for her.
Okay, Sriram. Manasvi, are we audible for you?
Yes, ma'am, I'm audible too.
Then please answer. How do you assess for front of neck access in these patients?
Sriram. Yes, ma'am, I'm audible too. But by seeing any scars or neck swelling or history of neck surgeries in this patient, and we'll be seeing who will perform front of tracheostomy.
So, as this is a difficult airway.
Ma'am, am I audible?
Yeah, you are audible. Please hear and answer properly.
By seeing any scars or neck swelling or history of neck surgery.
How do we keep a difficult airway card ready in these patients?
Hello, ma'am. Hello, ma'am.
Ma'am, excuse me, ma'am. There is a lot of disturbance. Neither are you heard properly, nor is the student heard properly.
Oh, we are sorry, ma'am.
You continue. Meanwhile, if you want to show the MCQs, you can show the MCQs till you correct your connectivity. You can show the MCQs till you correct your internet connectivity.
You need to unmute yourself, ma'am. Unmute yourself, please.
Unmute yourselves and
I think
please
the
continue.
internet connection is a little weak there.
How do you prepare with the difficult airway cart in these patients, Manasvi?
For difficult airway, I'll be keeping the cart with drawer 1 consisting of laryngoscope, video laryngoscope, bougie, stillet. And in drawer 2, I'll be keeping mask ventilation and alternative intubation plan like oropharyngeal airway, flexible fiber optic bronchoscope and all. And in drawer 3, I'll be keeping ready for equipment for rescue ventilation and tube exchange. Like supraglottic airway devices like IGEL,
Ma'am? Ma'am? I think there's some problem. Meanwhile, Dr. Prakriti has got the
Yes,
MCQs.
I feel there are, if Dr. Sriram and Dr. Manasri, one of you can just log out. There are too many machines on the same network, I feel. So the internet might be compromised.
They have all logged out. Hey, the problem is with Dr. Manasvi's in it. Connectivity.
Do we have the MCQs, ma'am?
Dr. Manasvi?
Sir, I have the MCQs.
No, wait. The MCQs have to be discussed. It's not just the answering. They have to be
Correct.
discussed.
Correct, ma'am.
Let the teachers come.
Mhm.
Dr. Manasvi? Dr. Manasvi? Yes, ma'am. Madam, please come online again. Okay, there is some problem with their electric connection and some problem is there. So, Dr. Prakriti, you please start sharing the MCQs for today. Please unmute yourself. Till they come, let us discuss the MCQs. Make it widescreen, yeah. Start reading the questions.
Ma'am, the first question is, intrinsic muscles of larynx are supplied by a recurrent laryngeal nerve except first option, posterior cricoadenoid, second option, lateral cricoadenoid, cricothyroid, and the last option, transverse arytenoid.
Read once more the options.
The options are the first option, posterior cricoadenoid, second option is lateral cricoadenoid, the third option is cricothyroid, and the fourth option is transverse arytenoid.
The audience, please type your answers in the chat box. This has been already covered by the teachers. Just see what is the maximum response. Which option? Prakriti, which option? I
Yes,
think
ma'am.
most of them are giving option C. Any
Yes.
more takers? Let's wait for some time.
Sure, ma'am.
Okay, so except for an isolated A, most of the answers, the options are option C, that is cricothyroid muscle.
Yes,
So
ma'am.
is that the right answer, Prakriti?
Yes, ma'am.
That's the right answer?
Yes, ma'am.
Okay, good. Now go on to the next question.
So the second question is calculate pack years. If a patient smoked 20 cigarettes per day for 20 years, so the pack years will be option A is 10 pack years, option B is 20 pack years, option C is 30 pack years, and option D is 40 pack years.
Once more, the options.
So the options are calculate the pack years. If a patient smoked 20 cigarettes per day for 20 years, option A, 10 pack years. Option B, 20 pack years. Option C, 30 pack years. Option D, 40 pack years.
So most of the answers have option is D. That is
40 pack
40
years.
pack years. But then I would like to ask you, Prakriti, what is 1 pack year?
Ma'am, it's the
That
number.
will be another MCQ. Yeah.
Yes, ma'am, it's the number of cigarette that has been smoked per day into multiplied by the number of years it's been smoked.
Array, great. Very good. Very good. Okay. So
answer
now
is
it became a
20
question
years.
answer between me and you. Okay. Ma'am, are you ready?
Yeah, ma'am. This,
Sureshri, ma'am, are you ready? Shall we continue?
yeah, ma'am, we can
Okay.
continue.
Okay.
The answer
So-
for this question is B. 20 pack years is the correct answer.
Okay, so the audience didn't get it right.
Because 20
Okay.
cigars
Because
means
each
1 pack.
pack contains 20 cigarettes.
20 cigarettes.
Okay, okay. So go on to the next MCQ now, Prakriti. Some 4 MCQs we can
It's
finish.
only not
Yeah.
just the one.
Just a minute. The third question is, what is the most common cause of preoperative anemia in carcinoma larynx? So the first option is anemia of disease. The second option is iron deficiency anemia. The third one is related bleeding. And the D is megaloblastic anemia. Option A is anemia of chronic disease. Option B is iron deficiency anemia. Option C is cancer-related bleeding. And option D is megaloblastic anemia.
Common cause of preoperative anemia in carcinoma larynx.
So answers are pouring in B option. Ma'am, what is the correct answer?
Ma'am, B is the correct answer.
Iron deficiency anemia.
Yeah.
All right. Okay. Ma'am, I think you can go on with the discussion again.
Okay.
You can show
We
the
have
MCQs
finished the
afterwards.
case discussion. We'll put questions to Manasvi. Is it okay, ma'am?
Yes, yes. If everything is okay with your internet connectivity, you can go
Yeah.
ahead.
Right. Manasvi, how do
Yes,
you,
ma'am.
what are the 5 questions you will ask yourself before you start this case?
I'll be asking whether will I be able to pre-oxygenate the patient or will I be able to use face mask ventilation for this patient? And third question I will ask is whether will I get a good view of COTS? And fourth question I will ask is will I be able to intubate the patient? And fifth question is if the intubation is failed, whether will I get a free access? Is it easy to get a free access? Front of neck access to this patient. Easy front of neck access to this patient.
Okay. Once you are prepared for that, how do you prepare for FONA in case of difficulty? How do you prepare for front of neck access pre-operatively? Manasvi. Manasvi, please answer.
In case she is offline, somebody else can answer for her.
Pre-operatively, I'll be checking whether
Ma'am,
the
in case she has a
patient
problem,
has
somebody else can answer for her.
any scars or neck swellings in history. I'll be asking swellings or history of audible.
Ma'am, you're audible, but Dr. Manasvi is not at all audible.
Okay, ma'am.
Somebody else can speak for her,
And
Manasvi.
Praveen will
Instead of
answer
me,
for
you
me.
can give to one of
Yes,
your
Sriram? Yes, Sriram.
you can give to one of your co-PGs to speak. Dr. Praveen can speak for her.
Yes, ma'am. Am I audible?
Yes, you are.
Assessment of
Please go ahead.
fauna is like any scars, any neck swellings, history of any neck surgeries. And one more thing is who will perform the front of neck axis, whether the airway would be a cricothyroidectomy or a tracheostomy. Midline, if it is cricothyroid but tracheostomy, midline lead marks. The midline and the lower edge of the cartilage, cricoid cartilage, and suprasternal notch should be marked, and local anesthetic infiltration should be done advanced.
So why pre-op tracheostomy is avoided? Hello, Manashvi.
Yes,
Why
ma'am.
preoperative tracheostomy is avoided in this case?
Tracheostomy is avoided because we'll have a longer disease-free segment of the trachea to be available for the creation of stroma for after laryngectomy, which can help in preventing complications like recurrence of stromal recurrence. And also it prevents improper wound healing in the patients.
So how do you pre-oxygenate?
We can pre-oxygenate the carcinoma larynx patients by high flow nasal oxygen. It is a simple method. And if the CPAP is available, we can go for CPAP, or we can no DSAT approach can be done in this patient where nasal prongs will be used and the patient and then oxygenation can be maximized by addition of a conventional face mask using the nasal oxygen during effort securing a tube approach. And Thrive can also be used where transnasal humidified rapid insufflation ventilator exchange can be done. And in all these things, position is crucial and is having the patient in a position where he is most comfortable and breathing is usually where he is comfortable can there we can do pre-oxygenation in these patients.
So what are the, do you face any problem with bag mask ventilation in these patients?
No, ma'am. I did not have any bag and mask ventilation in this patient. Problem with any bag and mask ventilation.
Okay, if the glottis is closed, will we face any bag mask ventilation? Then how do you overcome that one?
If bag and mask ventilation will be difficult when there is a narrow laryngeal inlet, and immediately if we do not will be not able to do bag and mask ventilation, then we can immediately go for next plan, like we can intubate the patient, or we can go for front of neck access to the patient.
So what is the best device for intubation in such cases?
Normal in my patient we have gone for video laryngoscopy where we can visualization cords can be done for laryngeal inlet.
So in these cases, you are expecting some difficult intubation. Can we go with awake fiber optic intubation?
Awake fiber optic intubation we cannot go, ma'am, because if we pass the bronchoscope through the laryngeal inlet, there will be a cork in bottle analogy where there will be an unwanted situation where the bronchoscope will be stuck in between the cords, and by this the airway will be totally cut off. So it is better to avoid awake fiber optic intubation in these patients.
So what is the ideal muscle relaxant that you use for the intubation?
Succinylcholine choline is the we can use succinylcholine because it has a short duration of action, and we can use rocuronium because of its rapid onset and also for long duration of action, and we can reverse it with sugammadex.
So which is ideal, succinylcholine or rocuronium?
Rocuronium is ideal, ma'am, if we have available of sugammadex.
Because we take multiple attempts in difficult intubation cases. So what are the ideal techniques for induction and maintenance of these cases?
For these patients, ideal technique is one where we can be passing of endotracheal tube with induction with propofol and intubation with giving muscle relaxants like induction with chironium or rocuronium or succinylcholine. And under one is we can go for inhalational induction, and also total intravenous anesthetic can also be used in this patient.
For maintenance, which is ideal, either inhalational or total intravenous anesthesia?
Total intravenous anesthesia is ideal, ma'am, because if we use inhalational anesthesia, the gases will be going to the stoma.
So you said that the ideal muscle relaxant is rocuronium or succinylcholine. But in this case, you have used vecuronium for intubation. How do you justify?
Because already the patient has debulking surgery before itself, ma'am, and there is no difficulty in intubation for that patient. So, and we have choose vecuronium in this patient now, ma'am.
So how do you assess the size of the tissue?
We can in this patient we have assessed with rigid videolaryngoscope in this patient, and preoperatively we have done ultrasonography for measurement of distance between the vocal cords in this patient, and CT in CT images also we can see whether there is any obstruction or any supraglottic or subglottic lesions are there.
What type of endotracheal tubes are preferable?
Flexometallic tubes are preferable in these patients, ma'am, because there will be no kinking during the procedure.
So how do you manage the postoperative pain?
Postoperatively, we can multimodal analgesia can be done with IV NSAIDs like paracetamol, or we can use low dose morphine in these patients, or we can use patient controlled analgesia, and transdermal patches can be done. And supracervical plexus block can be given if the before itself for the postoperative pain relief in this patient.
What postoperative care we should take after undergoing the total laryngectomy with a tracheostomy?
Tracheostomy. First, we should do thorough suctioning to the patient because there will be copious secretion in these patients, and the suctioning catheter should be 2/3 of the tracheostomy tube. And one more thing is we have to humidify, humidification should be done, and inner cannula care should be done in this patient, and tube cuff monitoring should be done in this patient. And thorough stomal cleaning should be done, and we have to keep dressing changes should be done in these patients.
So you told that you have put the nasogastric tube at the time after the intubation.
Yes, ma'am.
So are you keeping after the surgery also?
Yes, ma'am.
Is there any room?
Because in the post-operative period, we had go for as the patient can do swallowing immediately in the post-operative period, and we have to start in enteral feeding within less than 24 hours to this patient. So I have kept nasogastric tube immediately after the intubation, ma'am, for post-operative care. For nutritional.
So suppose if this post-laryngectomy patient is coming for any other surgery or presenting in the emergency, how do you manage?
If the laryngectomy patient has come to the surgery, we have to check whether the patient has stoma or not. If the patient has stoma, then it is a total laryngectomy. If the patient does not have any stoma, then it is a partial laryngectomy. In partial laryngectomy patients, we can easily do bag mask ventilation, and we can intubate the patient with small size endotracheal tube. And for total tracheostomy, if the stoma is present and the patient has total laryngectomy in those patients. In those patients, we can pre-oxygenate the patient with through the stoma, and ventilate the patient with pediatric airway mask. And we can intubate the patients with either J tube or Montado tube or flexometallic tubes.
Yes.
As is enhanced recovery after the surgery, ma'am. In this, nutritional assessment should be done preoperatively, and also For post-operative period, nutritional assessment should be done. And enteral nutrition should be, enteral feeding should be within 24 hours for this patient, and early mobilization should be done. And tracheostomy care should be done in this patient with and thorough suction should be done. And pulmonary physiotherapy should be done in these patients, and removal of any indwelling catheter should be done within 24 hours. And as the patient's thyroid gland will be removed, thyroxine replacement should be done in these patients. And there is no proper guidelines for ERAs for post-laryngectomy patients, ma'am. These are the comprehensive guidelines according to the...
Sriram, you have to answer. Are you ready? This, what's the role of lasers in carcinoma larynx?
Madam, there are a few types of lasers which can be used. There are CO2 laser. It has long wavelength of 10,600 nanometer. And there are other lasers like neodymium doped yttrium garnet and yttrium doped yttrium garnet, and other pulse dye lasers, ATP, potassium, titanium lasers, and excimer and holmium lasers, madam. Here, the longer the wavelength, it is like superficial and epithelium. The shorter the wavelength, it goes for the vascular lesions, madam. And the type of tubes we use for this laser surgeries are laser shield 2 type, madam, which has a silicon base, which has an over relay of aluminum. And the same like rush laser tubes, madam, one more type of laser which has a silicon base. And there is only one tube with metallic base, that is Codian Malcroft, which has 2 cups, madam. These tubes are not that much preferable compared to our normal tubes because they are heavy and bulky, which causes increase in the resistance of the flow, madam.
What are the precautions you take before start of surgery when you're using the lasers? Sriram can answer.
Yes, ma'am.
Praveen,
Basically, there are few hazards of the lasers, ma'am. This is called laser plumes. To prevent this, we just coil the laser ET tubes, and the laser plumes is at the site of surgery. Atmospheric contamination and destruction occurs, which causes interstitial pneumonia, teratogency, bronchiolitis. And tissue and vessel perforations are also there. Gas embolism can occur, and airway fire and explosion. For this, endotracheal tube fire incidence is pretty low, like common with the CO2 lasers, ma'am. So we have a protocol for fire hazards protocol, ma'am, airway fire protocol, in which we quickly remove the source of fire, stop the ventilation, disconnect the breathing circuit, flush the ET with water and saline using 50 ml of syringe and extubate, ventilate with 100% of oxygen, ventilate with 100% of oxygen, and continue the anesthesia. Laryngoscopy and rigid bronchoscopy to assess the damage and remove the debris. If any airway damage is there, reintubate the patient or perform tracheostomy if required, ma'am.
so what is the surgery which is done using lasers in this carcinoma larynx patients? Transoral?
Madam, you're not. Sorry, you're not. Madam?
What is the surgery which is done with lasers in carcinoma larynx patients?
Transoral, robotic, and laser surgeries, madam.
So why is team approach important in this type of surgeries?
Madam, it's basically an airway shared surgeries, madam. And
As we are at, basically the team approach is important because we are sharing the airway with the surgeon, and are also in anticipating difficult airway. It will be easy for airway access if the supporting team is present, and this will be enhanced. There will be enhanced expertise and skills for more comprehensive approach to the difficult airway. And it promotes clear communication and coordination among the team members existing, that everyone is aware of the situation and team can implement strategies if there is any failed intubation. So, and even ENT surgeon can also attempt for front of neck access in these patients. So team approach is very important.
Okay, with this, we finish our discussion. Dr. Prakriti and Gayatri, maybe you can share the MCQs and ask her for further discussion.
Sure, ma'am. I'll just share the MCQs once again.
This
So,
already finished.
yes, ma'am. Just the next question. Ma'am, should I read out the question?
Yeah.
Okay, ma'am. The fourth question is, are PFT relevant in carcinoma larynx? First, true. Second, false.
Question is here whether it's related to anesthesia or a surgery or something else. What true for what? That's the next part should be clear. If you are going to give anesthesia management, that is it should be A. If it's not related to anesthesia, it should be B.
This EFTs are not very useful in carcinoma larynx patients, so we thought they will answer this as B.
Madam, with the type of muscle relaxation you are using with the deranged RFTs and how are they going to behave? So that is the thing of concern with the invariably these patients are emaciated, they are not having a good intake. So that part of also the anemia is of not just of iron deficiency, it is of chronic disease also basically if you go. So that was also a part of A and B, the first part. And here also the RFTs and PFTs, both, if you ask the PFTs, because if invariably these patients can go to the post-operative, what you call the ventilatory support, many of them, depending upon the degree of invasiveness and of the grading of the carcinoma of larynx. So how, if the PFTs are of not optimal value, it's very difficult to wean them off also from the these ventilators. So I think it's a very tricky question. From anesthesia point of view or from a surgical point of view, you have to see from both the sides.
For PFTs are useful for assessing the lung reserve in these patients. But as they are having the upper airway obstructions, we cannot get accurate value to predict the risk stratification.
Yeah, because difficult. And see, over a period of time, the people, when these represent or present to yourself to the PAC clinic, invariably they have got a compromised lung with atelectasis, with some respiratory infections also, with the carcinoma larynx, not able to clear many of the bacteria or any pathogens from the function of the microvilli is also getting lost into these type of patients. So the lung is almost a compromised structure in these patients, which you may not be able to evaluate. Even if the growth is inside, I think the resistance increases, the airflow may not be of that much dynamic value. So whenever you are doing the PFTs, they may not reflect the true value of the lung. They may not reflect the true dynamics of the lung. So these are very difficult actually. So both answers can be good or bad depending upon the anesthesia management concern, the surgical management concern. But definitely, ma'am, when these patients go to the post-operative ventilatory support, I think there comes the real role of the PFT. Rather than PFT, I think the other investigations, if you go through the where you can always have, I think nowadays with the perioperative, intraoperative focus lung ultrasound is a very, very good, investigation to see the degree of alveolar involvement in that electrolysis or recruitment. That is, can also be seen with the lung waters there, with the post-operative, edema or something like that, where the ventilator support requires for minimal period. So many issues are concerned. I think going forward, whatever written in the books, I think it is going to be rewritten in the coming days with the advent and refinement by the newer investigation modalities or diagnostic modalities also.
Okay.
I agree with ma'am. Just one thing regarding PFT and CLRN. Will it not be helpful to know whether it is a fixed extrathoracic obstruction or a variable extrathoracic obstruction? That way also PFTs can be useful as such.
Nishant, what happens actually in this circumstances, actually when the carcinoma larynx occurs, how much have they caused the erosion of the tracheal rings, basically the cardiac ring? That is not sure. Because under anesthesia, the collapse may be much, much more than what we can anticipate in the normal awake dynamic patient. So even if the you what I think you are talking about is the inspiratory and expiratory type of mechanisms, the wall mechanism, the growth can put a resistance or a obstruction to the airflow. But under anesthesia, the muscle relaxation, when you are not getting the support of the cardiac rings, that the trachea can, the larynx can suddenly collapse, and you can go into something which you never anticipated in these type of patients.
Correct.
But next question.
Yes, sir. So the next question is, what is the ideal device for intubating the patient of laryngeal carcinoma? Option A, fiber optic bronchoscope. Option B, video laryngoscope. Option C, both. And option D, none.
I will go with C actually, because the fiber optic and video laryngoscope both you can be very helpful, but best part is the C. You can have the best of the both the things in this. That what Dr. Nishan just mentioned about the dynamicity of the collapse of the laryngeal muscles or laryngeal tissues into the main airway pathway. So I think both are very good. I don't know what Sureshri madam wants to convey. I think
No, sir, actually, awake fiber optic bronchoscope is very problematic because they said it is going to obstruct the whole lumen and tube will not be able to be negotiated. So ideally, they say that video laryngoscope is useful with the proper pre-op assessment.
the only, ma'am, see, the only catching point here is, see, you are doing the video laryngoscope. The tip of the blade cannot go beyond the epiglottic fold, glossoepiglottic fold. Okay. So now what happens? The growth, we may not be knowing the growth is extending up to what extent actually. So if you do a video laryngoscope, you at least get a defined pathway for the bronchoscope also to go beyond that. So bypassing the growth under the anesthesia part. Awake is okay. Now I agree with you, ma'am. Awake is always a difficult choice to go through that, and how much friable the tissue is also. And you're touching the, because you are not going under vision of direct. You may be just having the anterior vision only. The lateral vision you may not be having, which may be rubbing against the what you call that the friable tissue leading to the bleeding and later on causing the airway catastrophes. But in if you are using both, the video laryngoscope will give you a very good pathway from where you can easily negotiate or go through the with the fiber optic under anesthesia, even if the tissues are collapsing or something like that. So I think even if you go with the normal consensus over a global consensus for the present day scenario, in these type of cases, ma'am, the hybrid approach, that is using both the fiber optic as well as the video laryngoscope, is the ideal approach for managing these type of airways, ma'am.
Okay,
I
so
think it's
C is the
coming up.
answer for that. Okay,
An
sir.
answer can be both, ma'am, but depending on the, and then the last part is the comfort of the anesthesiologist, on which they are really comfortable. I suppose I'm using the video lens for the first time. I may be doing the more harm to the patient rather than the benefit of the patient. So I think which you are very much comfortable, that's the best technique. But ideally, the both the techniques, if you make it a hybrid, very good for these type of patients, ma'am. Very good for these type of patients.
Next question.
The next question is, what is the ideal muscle relaxant for intubating a patient with carcinoma larynx? First
This I
option,
think she explained, Manasvi explained very properly. She explained it. Ideal is the recognizability of schematics, no doubt about that.
Many have answered B, I think. So.
Yeah.
Next question.
Next one.
which of the following factors increase the risk of laryngospasm during anesthesia? First option is deep anesthesia. Second is laryngeal edema. C is airway instrumentation. And D is all of the above.
Deep anesthesia, how will it increase the laryngospasm? That is illogical. Laryngeal edema is already there. So laryngospasm with the laryngeal edema is a contributing factor. No, it's not exaggerating, it's a contributor to that. Airway instrumentation, definitely if the anesthesia is lighter. Definitely do. I don't know the rest. Just trying to doing my logical things because a few times I've got these cases done with all type of the what you call
Yes, sir. Airway instrumentation in lighter planes, that is more common to cause laryngoscopy.
That's what, ma'am. See, I think experience is speaking here. Good for the PGs also to know about that. All of the above is a wrong answer. Deep anesthesia is always, I think, the best if you are very well versed with the airway management techniques.
Yeah, sir. Right. Next, ma'am.
Just a second.
This is the last question.
Patient with a history of laryngeal cancer and radiation therapy is undergoing surgery. Which of the following is a key consideration for anesthesia? First option is the patient is likely to have a normal airway. Second is the patient may have laryngeal fibrosis or scarring. C is the patient will not experience any complications related to radiation. And option D is patient is likely to have a normal tolerance to anesthetic agents.
Answer you have already given. Very clear, straightforward answer.
Most of them are answering B. That's correct.
The B, I think, is the correct answer. You don't have to read other one.
Right.
All finished?
So one more question is there. What is the ideal tracheal tube after creating
Waiting.
the stoma? The first option is flexometallic tube. Option B, J tube. Option C, Montano tube. And option D, all of the above.
What is ideal tracheal tube after creating the stoma? Which of them is good to the radiation? If you go for the laser part.
Ideally, it's a Montano tube. C is the answer. All the others also can be used, but if we say it's ideal, we have to say Montano tube.
Montano, no, ma'am?
Yes. Okay, this finishes all questions, sir. So I would like to ask any questions to the postgraduate, please.
Ma'am, there was one question I think you asked at that time about the preoperative tracheostomy.
Yes.
I could not hear at that time. There was some disturbance. What was that question and what was the answer? Can you repeat it now?
Why pre-op tracheostomy is not advised in carcinoma larynx patients?
Yeah, ma'am. Not advised.
Not advised.
Yeah. The reason, ma'am?
One is there is a chance of recurrence of the tumor in the remaining stoma. The other one is poor wound healing is also one problem.
Great. And yeah, that was true. So I was thinking that you advised the preoperative tracheostomy. No, so I think it's not advised. It's not advised. And one more reason is suppose if I am in the surgical team, I would like to have as good as healthy areas around the carcinoma. So I can define my dissection planes. And moreover, the vascularity of the area is also a concern. When the one area is fibrous, must have given some radiation, scarring, fibrosis. And when you're going for the stoma, when it bleeds, vessels retract, you may not be able to stop the bleeding in this type of patient. You can have a catastrophe in the bleeding also, because these are the major arteries around that scarred area of the radiation fibrosis, the preoperative radiation. So these were the two factors which I would have liked to add in that particular part. So before going for the question, let us, okay. Ma'am, any other question, Prakriti and Gayatri?
No, ma'am. There were no other questions in the chat box today. Just that histopathological examination was asked and Dr. Praveen had answered it in the chat box.
Okay, fine, just fine. I think the class has been a good class. It's a difficult one, and they have finished in a very good time. Although slight that problem was there, which I just happened to see that about the technicality of.
Sorry for that, sir.
No, sir. Sometimes it happens. Sometimes even in our area also, you may be having a broadband. What happens, and these suddenly they go into out of the picture. So I'm just going to share my screen, ma'am. Is it visible to you
Not yet, sir.
now?
Yes, sir. Yes, sir.
So, ma'am, your name is visible.
Yes, sir. Thank you, sir.
So, ma'am, really, ISA national team is entirely thankful to you for being leading this particular class. A wonderful class, very well managed, and basically the concepts are clear. The PGs can go through it later on into this one YouTube at ISA NHQ. The recording will be available. And you being as a team leader, ma'am, really thankful to you for this particular class, ma'am.
Sir, if you give me a minute, we wish to thank our Government General Hospital Superintendent Dr. A. Venkateswara sir for giving us this space and internet facility.
Yeah, is he available here, ma'am?
Sir, he's here, sir.
Yeah, please call him. I will stop sharing for the time being. Let him, we will pin him also.
Sir, good evening, sir.
Yeah, sir. Good evening. Very much good evening, sir.
Good evening, sir. I am just junior to Madam Suresri. I am also anesthesiologist.
Very great. Great feeling.
Till 1st November 2024, I was HOD here and I got promoted as Superintendent Government General Hospital, Vijayawada.
Great, sir.
So thank you, sir, for giving me this opportunity to host this a good class.
Yes.
Thank you, sir.
It's a really good class, sir. Thank you for your being there as the, providing the opportunity and the base for conducting such an academic event and encouraging your this one department of yours. We always wish that the anesthesiologists should be sitting right at the top in the institution as the administrators. That will definitely lead to the, the further awareness and the importance of the specialty into the general public. Thank you, sir, very much for being a rock solid support behind the Department of Anesthesiology. So we are really grateful to you, sir.
Thank you, sir.
Thank you, sir.
In the meanwhile, I will continue to felicitate our faculty. So we have already felicitated our HOD, Madam Dr. T. Sureshri.
Thank you, sir.
And next, Dr. Govardhani. Madam, you have also done a wonderful work. I know that there are 3 PGs, you're preparing them. It's not a work of Dr. Sureshri alone. It's you also. They are doing much active work. So thank you, madam.
80% of the credit should go to her, sir.
So, ma'am, we always know because how the things really work out in a medical college.
Yeah.
So, Dr. Govardhani, we are really thankful for you.
Thank you, sir, for giving this opportunity for us.
Taking this class to this level. Thank you, madam. Thank you very much.
Thank you, sir.
And Sriram, you did a wonderful job. Good. Keep on going. Praveen, yourself, then Manasvi. All 3 of you were good in answering. And as advised to you in the earlier part also, that you did not do any blunder. Thank you, all of you. And I think you have passed your pre-final now. So you will be appearing for the final, which Dr. Sureshri and Dr. Govardhani will give you good numbers in your final examination. And Dr. Prakriti, she just appeared for her post-graduation. Prakriti, you and Gayatri, you both, when you pass out, you just, you have already passed out. When you get your passing certificate, please hand over that so that we can convert you to the LM. That like membership is very important. So as soon as you get the certificate, send it to the national headquarters for conversion ALM to LM status. So thank you to all of you. Dr. Madhuri, want to ask something or convey something, please?
Yeah, thank you, sir. I just wanted to add that these cases of CA larynx often come for biopsy of the growth, and these cases are very challenging. Actually, my first case, which I did after passing out, was a case of total laryngectomy only. And when you take these cases for biopsy, you have to discuss with the surgeon as to how much is the glottic chink. Will you be able to intubate if needed? So communication with the surgeon is very important, and that judgment is also important. So if you I think there's already a question in the chat box regarding TIVA. So how will you give anesthesia for a case of biopsy of the CA larynx? Can one of the PG students tell, Dr. Praveen or Dr. Manasvi, if it is just a biopsy of the CA larynx of the growth? Because before the patient is taken for laryngectomy, it is definitely going to be taken for biopsy. And many times we are called in to give anesthesia for that.
Dr. Madhuri, as an
So,
external, I have already given them a passing mark, so we should not be asking
no, no.
questions.
So
to them.
how will you?
I will be answering for them. See,
No,
if I
no.
got a cat,
Or shall
if I
I? I
got a
will only
ketamine,
answer. I
if
will
I got
only
a
answer.
ketamine, if I got a ketamine,
No,
I
no,
will
I
go
will
to the
only answer.
ketamine.
I will.
The best anesthesia in the current situation, the ketamine will preserve the reflexes, the tone of the
Yeah.
muscles. You go for it, but see, that's not the coordination and communication of the surgeon. You also see the what you that surgeon's acumen is, clinical acumen, surgical
Yes.
skills, his
Yes.
behavior, his conduct, his empathy and
Yes.
sympathy toward the patient. Because sometimes they were a very new surgeon, they just wanted to wash off their hands, doing
Yes.
something,
Yes.
adventurous like that. So all these factors have to be considered.
Yes.
I think
Yes.
here comes the role of HOD like Dr. Madhuri, who
No,
will
sir.
see who
No,
will see
no,
all the
there's no
factors
question of
concerned.
HOD.
Who will
Sir,
see? No. You have to see. That's because your juniors may not be, they may be overwhelmed by the situation. They say the surgeon has to do this case. It's very important. We have to take biopsy. We have to devise a plan. I think here comes biopsy is not a small case. You have asked a very pertinent question. One of the very important part. Any misgiving here, you will lead to a catastrophe there. Catastrophe, I'm telling you.
exactly.
So here
Exactly.
comes the role of the senior most anesthesiologist who have passed through the ages, how these anesthesia complications happen and how you're dealing with them. So this, I think,
Yes.
if I've got a ketamine with me, it's the safest drug for me to use for the biopsy.
I'm
Everything preserved, I'm telling you for this.
Yes. So I agree with you totally. And ketamine is good, but ketamine can cause a bit more of bleeding also from the biopsy site. So
Give
we can
midazolam
even use
so that
dexmedetomidine and propofol, ketofol. All these can be used. And
that
the worst
combination.
part is that after the biopsy, the edema develops. And post-operatively, the patient goes into obstruction, stridor. So many things can occur. So you
How
have
much
to
tissue you
use,
have to take, that is also important in this
yeah,
thing. That's why I think the surgeon's skill and acumen is very, very important.
yes. So the obstruction will increase after the biopsy, and you have to use various maneuvers to bring down the edema, laryngeal edema. Okay.
Fine.
There's one more
That's a good
question
point.
in the chat box, Prakriti.
What is that?
The one more
Oh
question
no,
is
somebody wants to ask a question, Dr. Saurabh. He has raised his hand.
he has raised his hand. Saurabh Bija.
Yeah, good evening, ma'am. I just wanted to ask the question, what should be the ideal apnea time should be given to the surgeon for making the stoma?
Apnea time means after giving anesthesia, or you want to give
So
some
when surgeon is making stoma, uh,
during
during
preoperative or intraoperative or postoperative?
intraoperatively.
Intraoperative.
So
I
what
think
should be the ideal apnea time should be given to the surgeon?
I think when you have already intubated the patient is already intubated under controlled ventilation. The stoma part, I think is you are more in a controlled situation there. The difficult is the pre-operative and the post-operative if you are doing it. Intraoperative things under the intubated patients is always under control. So apnea time, I don't think so. We have to give much apnea time there. I think the patient, when he's creating a stoma, there is a minimal movement. You can have a very, very lesser tidal volume you can give so that the muscle, the muscle contraction relaxation is not to that extent that the stoma's ideal size is not achieved by them. So giving the good tidal volume, small tidal volume with a increased respiratory rate, either manually or on the ventilatory part, you can give, I think. That's under controlled condition. Only the preoperative and postoperative is a difficult one. Then I really think it's a very difficult situation for that.
Okay, thank you.
We can allow apneic oxygenation also during that time.
Okay, ma'am.
I think when everything is under control, so apnea is out of the question also.
No, so, sometime surgeon they pull out the tube, tracheostomy tube, and they start making stoma by suturing. So
No,
for
they
some
just
time,
see when already they have done it, na, already they've created a stoma, I think. When they reach to the tube, that means they have identified the tube. Bulb is also very near it. Bulb is also very near it. So ideally, you are basically secured. If you are
We
secured that the
withdraw
stoma is
the
there, it's a
withdraw
direct
the
under,
ET tube little bit
it's
while
a,
creating the stroma. That's all.
ma'am, it's already direct under vision only.
Yes, yes.
Under vision is a very safe, and as surgeons say, if they are good in making a stoma, even they also know the importance of the lack of oxygenation apnea in these patients. So whenever they reach the stoma, I think securing the bleeding points and other thing is important to them. If every hemostasis is maintained, I think they will be very quick in allowing you to continue with the tracheostomy tube or something like that. Any even oropharyngeal airway they can put into the stoma, whatever the devices are available with you at that time.
In this patient, we have put a flexometallic tube only, sir, into the stomach.
Anything you can put with the stoma. When it's under vision, then there's no issue about
Yes,
it.
no problem.
Only thing is, if it's very difficult, the bleeding mess is there. I think that if you have already achieving the hemostasis, only then you proceed with the complete stoma. You puncture the last fascia also, the last muscular part before you really go into the securing the airway.
So there's one more question being asked by Shobha Vatkar. Role of MLScopy under GA for biopsy.
It's a commonly done. Commonly done. We are doing that only for the last 20 years. Microlaryngoscopy with this one, everything done like that only. Madam will say on everything. She will let her contribute. Madam,
But
please.
you said under local, something like you said under TIVA.
Spraying 10%, 10%, even 10% of the local anesthetic. Many times the surgeon spray. But ma'am, I'm telling you, with the airway sharing potentiality, always like you should have a control over there, because we are not under the purview of medical legal litigation in these cases. So by going forward, when they are taking the biopsy, even under local blocks and local spraying of the anesthetics, where Dr. Madhuri also mentioned at that time that the bleeding can be sometime very, very strong when you puncture a vessel. So you have to be prepared for the all type of airway management in these cases. And even if you are going with the awake, with the local, with the spraying, so many techniques are there. Many people, have given them the lozenges of the also this thing. Then going with the blocks through the cricothyroid membrane to the other area structure. Then so many blocks are available now, which people have been using for the last so many 30 years. So that is not an issue. The issue is only when it bleeds, then only you have to be prepared for a management of airway. And I think there comes the role of the very senior persons who have seen these complications, not to panic rather than securing the airway at that particular time. Anything else, madam? Shobha, madam?
No, that position itself, like a shoulder extension with that ML scopy, they attach that gadget for that scope, isn't it? Do the patients
That's the
already?
most protective, madam. It's the most protective blessing in disguise for us also, that position. At least the gravitational factor is eliminated when you keep something under the shoulder. No? The gravitational part is helping you, and there is no aspiration of the blood, minimal aspiration of the blood, minimal chances rather.
But my center, it has always been done under GA, first of all, with that small size tube, ML tube, the GA, like. So that's what I am asking.
That's the best part, ma'am. That's the best part. Under GA.
Everything is in under your control. So that's what I feel.
Yeah, you should always be under control, actually. It's better to have a control. That's what I was saying, ma'am. Control has to be there, because you are, whether you are have intubated or not, you are responsible for anything happening on the table, ma'am, for these tables. Anything else, Prakriti?
Sir, no, sir. There's no more questions after this.
Great. So I think the class has been a very good class. Everything almost answered. So there is no suggestion or any raising of hands. So thank you everyone, especially the team from Vijayawada. They have done a wonderful job today. Got into the permanent recording of the ISA National Headquarter classes. So you will be on the YouTube, madam, forever. Those classes can be seen by anybody, and those pearls of wisdom will be taken by everyone while appearing for the examination. And our PGs will also be featured in those classes. So it's going to be a permanent feature of the ISA National Headquarters. Thank you, madam. Thank you with you and your team. Then I have to thank Prakriti and Gayatri because they are the very enthusiastic, the new postgraduate just going into the senior residency. And that my team of also Dr. Madhuri, Dr. Nishant, and Dr. Ridhima, they are always there for helping us in the formation and formulation as well as the conduct of this class. So everything comes out very good actually, apart from little bit of technical things sometime happening. Otherwise, everything is good. So thank you, everyone. So we will meet next Monday. Next Monday is going to be a very dynamic class. We will be discussing the case scenarios where we really require the ventilatory supports, how to bring them out of those. So those are very practical classes taken by one of the renowned faculty of the country. So we'll be meeting next Monday. That is 14th of April at 6:30 p.m. Till then, so good night and long live ISA.